we knew that peritoneal colorectal carcinomatosis is a very serious condition, and today with the modern chemotherapy for patients not operated on, the prognosis is never more than 16 months overall survival. And when the patient is amenable to complete macroscopic resection, that means complete removal of the disease in the abdomen, the prognosis can reach 40 months overall survival, and in those cases we are able to cure 16%, about 60% of the patients. So it's why we use for a long time cytoreductive surgery in addition to HIPEC. And the two components, the two parts of the treatment have never been separated. We didn't know the exact role of the HIPEC in this package. It's why we randomized the HIPEC for patients completely resected to know the exact role of this particular heated chemotherapy given intraoperatively.
And how did these results turn out?
The results are that we have no difference between HIPEC and non-HIPEC concerning the mortality, post-op mortality, concerning the early side effects, the early complication after the operation. But we had significant difference concerning the late severe complication within 60 days. And regarding the survival, there are no difference between the two arms, between HIPEC and non-HIPEC, concerning the primary endpoint, which is overall survival. And we were amazed to see the high rate, survival rate in the non-HIPEC arm, because our hypothesis at the beginning was to consider that it would improve survival from 30 to 48 months, and we found 41 months in the non-HIPEC arm, which is very high and unexpected. It's why probably the study is negative.
And there were notes about possible use for HIPEC, even considering all of this, for medium tumor
Yes, because we perform a subgroup analysis showing that for this particular group of patients, HIPEC could be beneficial for them. And we looked into 3 categories of PCI, the high PCI more than 16, the medium one from 11 to 15, and the low under 10.
And taking all of this as one lesson, how is this changing practice or changing care?
It will change practice, because we are not going to use HIPEC in every cases like today, and HIPEC could be reserved to the only medium range PCI patients.
And any final thoughts on between this and the presentation regarding mFOLFOX? How does that affect the landscape of pancreatic cancer care going forwards?
The pancreatic, it's very important for the pancreatic cancer, because the adjuvant chemotherapy improve a lot survival in the pancreatic study in the FOLFIRINOX. But we have to improve for the carcinomatosis. We have to improve chemotherapy as well, and research will be made in improving the drugs, chemotherapy, systemic, but also intraoperative probably, yes, using other drugs, other protocols.